Alright guys, we are picking up where we left off. We just finished talking about post-arrest. Make sure we remember do not hyperventilate, get a 12 lead, get vitals, and we're going to have to exit to an appropriate protocol. And that appropriate protocol is somewhat subjective based on the presenting signs and symptoms of the patient after arrest. Also make sure that you remember arrhythmias are common and usually self-limiting after ROSC, meaning they normally fix themselves. So we're going to navigate over to the hypotension/shock protocol. This is protocol number AM5 for your state protocols. We'll start up at the top. The key here, along with everything else we've talked about, is to try your best to identify the underlying cause for shock. What is shock? Shock is hypoperfusion, right? So in this case, in this protocol, hypotension and shock are kind of grouped in together, and then down as we go a little bit through the protocol, it will start to differentiate between the different causes of shock. We'll get to that in just a moment. At the top we have our history, our signs and symptoms, and our differential. We should, while we've been working this code, have been asking questions or trying our best to figure out a potential cause for this arrest, because that potential cause of the arrest is likely going to be the potential cause for them remaining hypotensive following ROSC as well. So let's scroll on down just a little bit. We have cardiogenic, hypovolemic, distributive, and obstructive shock. So cardiogenic, this is a primary heart issue. For instance, maybe the patient had a big heart attack and now they have lost the ability of their ventricle to pump very adequately. So this is a cardiogenic shock. Maybe the patient had nausea, vomiting, diarrhea for several days before they arrested. That may be a cause of their arrest. That may be something we want to treat, hypovolemic, low volume. Distributive, maybe they were in sepsis. They experienced septic shock. That would be a good reason to give vasopressors to give fluid. We're going to look at that. And or maybe it was obstructive shock, meaning maybe it's a pulmonary embolism, maybe it is a tension pneumothorax, hemothorax, cardiac tamponade, something along those lines. Or maybe, just maybe, it's a combination of one or two or three or more of these. But in general, we're going to start with the same intervention. And this intervention is isotonic crystalloid solution. And this is something that we should have already been doing because we've been working a code. And if you remember back to last week's lecture, when we're working a code, we want to make sure that we hang a bag of fluid because we're treating potential reversible causes, those H's and T's. Always think about your H's and T's. Your maximum amount of fluid is 2 liters. The state protocol does specify normal saline. Just know they had to put something in there. So you can also use lactated ringers. Follow your local agency's protocol, but LR or normal saline are both acceptable for this. We're starting with a 500 ml up to 2 liters max. We're looking for a systolic blood pressure of at least 90 millimeters of mercury or a MAP, mean arterial pressure, of at least 65 millimeters of mercury. So if we're not able to get the blood pressure where we need to, or for some reason large fluid boluses are contraindicated, then we want to consider the use of a vasopressor. And vasopressor, that term in general, kind of implies several different things. So first, it obviously is going to cause vasocompression, or vasoconstriction, I guess would be the proper term. So we're going to squeeze the vessels with a vasopressor. But vasopressor, the grouping, that category also includes inotropic agents and chronotropic agents, such as epinephrine, such as dopamine, such as dobutamine, and such as Levophed. We've talked about all of these drugs with the exception of Levophed and dobutamine previously, so we're not going to recap too in depth on dopamine and epinephrine. We're not going to talk at all today about dobutamine with the exception of one statement, and that statement is dobutamine is different than dopamine. Where dopamine is dose dependent and we have a low, medium, and high dose and our effect is different depending on how much we give, dobutamine is a pure inotropic agent. So we're not going to get much, if any, effect on the heart rate or vasoconstriction with the drug dobutamine. It's just going to increase myocardial contractility. That's all we're going to talk about dobutamine right now. That's the only thing that you need to know about it right now. It is not a commonly used drug in the pre-hospital setting. Dopamine you should be familiar with. Epinephrine you should be familiar with. The one drug we're going to add and we're going to go in detail on is Levophed. So let's exit out of the protocol and go over to your drug cards. Your drug card looks like this. Levophed is also called norepinephrine, or vice versa, however you want to look at that. You've heard the term norepinephrine a lot, and we learned weeks ago that norepinephrine is the primary hormone associated with the sympathetic nervous system. So therefore, when we give it intravenously, it's an exogenous chemical, and it's a sympathomimetic, meaning that it mimics the effects of the sympathetic nervous system. Here we have the term vasopressor again. We just talked about what that means. Now, under the action, it's important here, and this is the main reason that we talk about the affinity of alpha versus beta receptors with norepinephrine and epinephrine in weeks past, is because I want to make sure that you understand the effects of vasopressors when you give them. So epinephrine, we know, has a much higher affinity to beta receptors than it does to alpha receptors, which means, especially at lower doses, our primary effect of epinephrine is going to be on the heart tissue. So we're going to have an increase in heart rate, and we're going to have an increase in the strength of contraction. The higher the dose gets, or the more we give, the more vasoconstrictive properties epinephrine is going to have. Because remember, beta 1, beta 2, those are your cardiogenic receptors per se. The heart muscle itself has no alpha 1 receptors. Alpha 1 receptors cause peripheral vasoconstriction, arterial constriction, so on and so forth. So, that being said, norepinephrine is the opposite of epinephrine in a way, meaning that norepinephrine has a much higher affinity for alpha receptors in comparison to that of beta receptors. So, the primary effect of norepinephrine is going to be vasoconstriction. It's going to shrink the vessels. That doesn't mean that it does not have some effect on beta receptors, because it does. It can increase the heart rate minimally. It can increase the work or the strength of contraction, but its primary effect is on alpha 1 receptors, and it's very primary to alpha 1 receptors, meaning you're going to have very, very, very minimal, if any, effect on those beta receptors. You're going to really have to get a high dose to start having much effect on beta receptors. So it's a very potent alpha 1 agonist, even though it does technically stimulate beta 1. This alpha 2 should not be in here, and I will make sure that's deleted before I put that on your blackboard. So alpha 1, beta 1 are the two effects, but make sure you know it's primarily an alpha 1 agonist. All right, so that's important to know, and the reason that I make such a big deal about this is because if I am treating, say, two different kinds of shock, let's go back to our hypotension protocol, and let's say that I'm treating a cardiogenic issue. So the ventricles are having trouble pumping blood, right? Say that they have become ischemic from a heart attack, and now you've got all this dead tissue in the left ventricle, and so your ejection fraction is greatly reduced. It's 25%, and the heart muscle itself is just trying its best to keep up with the workload of the heart. So I need to give a quote-unquote vasopressor, right? So we said dopamine, dobutamine, epinephrine, norepinephrine, and there are others. Those are just the more common ones. All fall in this vasopressor category. And let's say that your agency allows you to choose which vasopressor you're going to use, which a lot of agencies do. Then it's important to understand that if I give this patient in cardiogenic shock norepinephrine, that may not be very good. Why might that be? I can't talk. Sorry. Why might that be bad? Well, the problem is if I squeeze arterioles, then I increase afterload, right? Remember that norepinephrine is not affecting the strength of cardiac contraction. It's squeezing peripheral vasculature. So if I squeeze those vessels peripherally, that increases afterload, which in return is going to increase the oxygen demand and the myocardial workload of the heart. So I'm taking a heart that's already working really, really, really hard to move blood out of it, and I'm making it even more difficult for that heart to pump blood out of it. But what if I was treating a patient in distributive shock? Remember, distributive means widespread vasodilation, so it's a septic patient, right? Septic shock. The patient's hypotensive now, and we're giving fluids. We've maxed out on fluids, and we want to do something different because their blood pressure is still in the toilet. Would norepinephrine be a better choice for a patient in distributive shock than it would be in cardiogenic shock? Of course it would, right? So this is why understanding how your vasopressor agents work becomes really pertinent. All right, let's go back over to our drug card here real quick. All right, so our dose for adults is 2 to 4 micrograms per minute. This is not weight-based, so it's not micrograms per kilogram per minute. It is 2 to 4 micrograms per minute, IVIO, We're looking again for a blood pressure of 90 or a MAP of at least 65. Your max dose is 20 micrograms per minute. Now, this is a drug that we do, if we have it available, you absolutely want to use an IV pump because it's going to be difficult to get this in an exact dosing. And yeah, 2 to 20 micrograms a minute seems like a really wide therapeutic index, and theoretically I guess it is, but this is also a drug that just a little bit too much too quickly can cause a lot of problems. So we want to be as specific as we can with our dosing. So if you have an IV pump available, use it. If you don't have an IV pump, maybe use a specialized drip set that counts the milliliters for you or something along those lines. All right. So let's flip back over to our hypotension protocol for just a moment. All right, and let's scroll on down. We're not going through again dopamine and epinephrine again, though you can consider those when treating hypotension/shock. When we get down into the pearls, it goes through the basis of each type of shock and some things that we should consider for those. I'm not going to go in depth on those because you all can read. So the basis for post-resuscitation is identifying the reason for arrest, if possible, and treating that issue. Remember that tachyarrhythmias especially are very common following cardiac arrest, meaning after ROSC, and that normally they go away on their own. So we are at a 2-minute mark, we have a rhythm check, pulse check. There is a pulse, it's really fast. I look at the monitor and I see what looks to be SVT at a rate of 184 beats per minute. The pulse matches what I see on the monitor, meaning their pulse is actually about 184 beats per minute. This may not be a patient that I want to immediately move to synchronized cardioversion on. Give it a minute. And I say a minute loosely. I'm not saying literal 60 seconds. There's not a specified time frame on this. Just reassess your patient. Check it out. You have to take these things case by case and figure out what the best treatment is going to be for your patient.